So in this video we begin our discussion on venous disorder. We start with our discussion on varicose vein. So there are two types, basically a primary and a secondary. So primary are those without any obvious cause, presence of family history associated with pregnancy, advancing age, and there is a history of standing for long hours. In contrast, secondary is one which is associated with your DVT, Parker-Weber syndrome, Klippel-Trenaunay syndrome, a pelvic mass, or a retroperitoneal fibrosis. Then there is a very important classification with respect to your varicose vein, which is your CEAP classification. So we will discuss the C subsequently. First let us discuss the etiological classification. So EC is your congenital, EP is your primary, then ES is your secondary, and EN is your not specified. Now anatomical classification includes your AS for your superficial vein, P for your perforating vein, then D is for your deep vein, and N is your not specified, right. And the pathological classification includes your reflux, O for obstruction, and N is your not specified, right. So this is your EAP, and now coming down to the C classification, your C0 is when there is no visible sign of venous disease. Now C1 would include your spider vein or your telangiectasia, and they may also include your reticular vein. So C2 is your varicose vein. Now C3 is your varicose vein plus edema. C4 is your varicose vein associated with your trophic changes. Now 4A is your pigmentation, purpura, or eczema. Now C4B includes your lipodermatosclerosis and your atrophic Blanche, and you have C4C, which is your corona phylbacteria, right. So this is your C4 classification. Then you have your C5, which is your healed venous ulcer, and C6 would be your active venous ulcer, right. So this is about your CAAP classification of your varicose vein. Now let us look at the images. So this first image is your telangiectasia and reticular vein. So telangiectasia are your veins less than 1 mm in size, and your reticular veins are your veins which measure 1 to 2.9 mm. Right. Then you have your saphenous varix, which is your painless groin swelling which is apparent on standing. Then we have your lipodermatosclerosis changes, which is your chronic inflammation and fibrosis of your skin and the subcutaneous tissue, and your atrophic Blanche, which is your localized area of trophic white skin. Right. So this is over here pigmentation, where you can see your hemosiderosis, and this image is demonstrating your severe eczema. So you might be getting an image and asked regarding your clinical classification, and regarding your corona phylbacteria, this is basically a malleolar flare. So it is a fan shaped pattern of telangiectasia on the ankle of foot. So please remember about your corona bacteria, which has been a recent addition in your CAP classification. Now this is your image of your varicose veins. So varicose veins are more than 3 mm, right? So varicose veins are more than 3 mm in size. Now investigation would include your duplex ultrasound scanning, which would be mainly to demonstrate your reflux obstruction, rule out your DVT, and identify any pelvic source of reflux or obstruction, and identify the suitability of incompetent superficial vein for different treatment. Now regarding your treatment, if there are signs and symptoms of your chronic venous insufficiency, then we go for your conservative management, which is a compression. Now if you find a satisfactory response, you continue your treatment. Now if there is an unsatisfactory response, you go for a duplex scan, and if it is a non-acute obstruction, then a venography and a venous stenting may be required. Now if it's a muscle pump dysfunction, then an exercise program would be needed. Now if it is a reflux, now if it is in perforator, then we do this subfascial endoscopic perforator surgery. Now if it is in your deep vein, then venography and valve reconstruction would be required, and in case of your superficial, you would need a venous stripping and your endovenous ablation, right? So right now the endothermal ablation has become your gold standard. So why has it become your gold standard? Because recent randomized control trials have proved it to be safer, higher technical efficacy, superior quality of life, cost effective, and look, it can be done in local anesthesia. So the various technologies for your endothermal laser ablation, endothermal ablation techniques include your laser and your radio frequency, right? So now the main differences between your endovenous laser ablation and your radio frequency ablation include, now EVLA, that laser can ablate any vein, whereas radio frequency ablation cannot ablate your tortuous vein. Now it can be used in the management of perforator veins, whereas radio frequency ablation cannot be used. It is inexpensive compared to your radio frequency ablation, and endovenous laser ablation can deliver target foam sclerotherapy, whereas in case of radio frequency ablation, it is usually an automated, and hence your learning curve is reduced, right? Then another important concept is regarding your tumescent anesthesia. So what happens with this is that it compresses the vein onto the treatment device and helps in the hydrodissection of tissues such as your nerve away from your zone of injury, and it also acts like a heat sink, that mopping excess of your thermal injury. So this were some of the important points with respect to your varicose veins. Now coming to another important concept in your venous disorder is your venous ulcer. So the most acceptable theory for this is your ambulatory venous hypertension. So you can see over here a marginal ulcer. So basically venous ulcer have your risk for your marginal ulcer, so which is a squamous cell carcinoma. Now the treatment would include your multi-layer elastic compression bandaging system, which is also called your Charing Cross 4-layer bandage. It includes your first orthopedic wool, cotton crepe, elastic bandage, and your cohesive bandage, right? A drug that has been used in the management is your pentoxifylline. Now what does it do? It increases your microvascular perfusion by decreasing the plasma cellular viscosity, right? Now we go down to the next topic of discussion in your venous disorder, which is a deep venous thrombosis. So what we have done is that we have taken the important tables from your Bailey and Love to understand this deep venous thrombosis, as the questions usually asked are straightforward from the table. So first, regarding your risk factors. So the risk factors could be your patient factors or your disease factor. Patient factors would include your age, obesity, varicose vein, immobility, pregnancy, puerperium, high dose estrogen therapy, previous deep venous thrombosis, and thrombophilia, right? And your disease or surgical procedure would include like trauma, surgery, malignancy, heart failure, recent myocardial infarction, paralysis of lower limb, infection, inflammatory bowel disease, nephrotic syndrome, polycythemia, paraproteinemia, paroxysmal nocturnal hemoglobinuria, Behçet's disease, and your homocystinemia. Now regarding the etiology, important concept to remember is your virtuous triad. So what is your virtuous triad? It is your endothelial damage, then you have your stasis and your coagulability. Right. So, please remember your virtue triad. Now, the abnormalities of your thrombosis and fibrinolysis that lead to an increased risk of your venous disease. Now, you have your congenital, like, which includes the deficiency of your antithrombin 3, protein C and S, antiphospholipid antibody or lipase anticoagulant, factor 5 leading gene defect or activated protein C resistance, and your dysfibrogenemia, and you have acquired, which includes your antiphospholipid antibody or lipase anticoagulant. Now, the clinical features would include your pain, swelling or white sinuous leg, which is also referred to as your phlegmatia alba dolens and phlegmatia cerulea dolens, right. Now, an important sign is seen, which is your resistance to calf muscle on dorsiflexion, which is your Homan's sign. Now, the various investigations that are used in your deep venous thrombosis include your D-dimer, duplex scanning, ascending venography, MRI and CT pulmonary angiography. And now there is an important criteria which is referred to as your Wells criteria, right. So, this Wells criteria for predicting your deep venous thrombosis, it includes your lower limb trauma or immobilization in a plaster cast, bedridden for more than 3 days or surgery in last 4 weeks, tenderness along the line of femoral or popliteal vein, entire limb is swollen, calf more than 3 cm larger circumference other than side 10 cm below tibial tuberosity, pitting edema, dilated collateral superficial veins, previous DVT, malignancy, intravenous drug abuse and alternative diagnosis. So, a score of 0, -2 to 0 is your low probability, whereas the moderate probability is a score of 1 or 2 and high probability is a score of more than 2. Now, similarly, we have a Wells criteria for predicting your pulmonary embolism. So, we need to remember this criteria also. A score of 3 is given if clinical signs and symptoms of DVT, that is your minimum legs swelling and pain on palpation of your deep veins. Then if you have alternative diagnosis, less likely than PE, then you have heart rate more than 100 beats per minute, immobilization for more than 3 days or surgery within past 4 weeks, a previous history of DVT, hemoptysis and malignancy, right. So, a score of less than 4 means PE is unlikely, whereas a score of more than 4 is suggestive of your pulmonary embolism, whereas in a score of more than 2 in case of your DVT in Wells criteria was highly suggestive of DVT. Now, there is another important table which is regarding your low, medium, high risk patient groups for venous thromboembolism. Invariably questions are asked from this table. So, what are your low risk? Your low risk includes your minor injury, minor surgery less than 30 minutes, any age and no risk factors, major surgery for more than 30 minutes, age less than 40 and no other risk factors, and minor trauma or medical illness. Then you have your medium risk factors, which include your major surgery, age 40 plus or other risk factors. Then you have your major medical illness, which includes a heart, lung disease, cancer, inflammatory bowel disease, major trauma or burns, and minor surgery or trauma medical illness in a patient with previous DVT, PE or thrombophilia, right. So, please do not get confused, these are not your high risk. So, what are your high risk? High risk includes your orthopedic surgery or your fracture of pelvis, lower limb or any major abdominal pelvic surgery for cancer. Then major surgery, trauma, medical illness in a patient with the DVT, right. So, if you have a surgery which is major in a previous history of DVT, PE or thrombophilia, that classifies it as a high risk, whereas a minor in surgery or a trauma in a patient with a previous DVT, PE or thrombophilia classified as a medium risk. Then we have your lower limb paralysis, that is stroke or paraplegia, and major lower limb amputation. So, this all form your high risk. So, this is a very important table from which your questions are asked. So, please remember your low risk, medium risk and your high risk. Now, moving down to the treatment part. Treatment is usually with the help of subcutaneous low molecular weight heparin. Then if there is renal impairment, so in such cases we use unfractionated IV heparin. Now, if there are patients of heparin induced thrombocytopenia, in those cases we use fondaparinux, which is an indirect factor 10A inhibitor, and bivalirudin, which is a direct thrombin inhibitor. Now, those who cannot be anticoagulated, in them we use a temporary measure with the form of your IVC filters, right. So, this is about your deep venous thrombosis. So, please remember this particular chart of your low risk, medium risk and high risk, as it is quite confusing and it is very frequently asked in your exam. And please do remember the Wells criteria also. Now, few additional topics in your venous disorder that we would discuss is the Klippel-Trenaunay syndrome. So, you can see the image over here of a Klippel-Trenaunay syndrome. So, it is a mesodermal abnormality, not familial. Now, it presents with your cutaneous nevus, persistent vestigial vein and varicose vein with your soft tissue and bone hypertrophy. So, these are your classical features of your Klippel-Trenaunay syndrome, which we need to differentiate with the Park-Weber syndrome, which we shall discuss subsequently, which is your arteriovenous malformation, right. Now, in your Klippel-Trenaunay syndrome, you have your deep venous, which are hyperplastic, aplastic and associated with your lymphatic obstruction. So, the treatment would include your compression hosiery, laser ablation of nevus, stapling of bone to avoid your any leg discrepancy. Then removal of your large superficial varicose vein and low molecular weight heparin, as they are at risk of your venous thromboembolism. Now, regarding your Park-Weber syndrome, so this consists of multiple AV fistula which causes a venous hypertension, ulceration and your high output cardiac failure. So, this is a very important differential diagnosis of your Klippel-Trenaunay syndrome. Now, we have this last topic, this venous entrapment syndrome. So, there are two common veins that are commonly involved, that is your axillary vein and your popliteal vein. Axillary vein gets your entrapped between your first strip and your clavicle, whereas your popliteal vein gets entrapped due to the abnormal insertion of which muscle, that is your gastrocnemius muscle. Now, this axillary vein thrombosis is also known as your Paget-Schroeder disease, right. So, this is your axillary vein thrombosis. So, this were some of the few important point concepts and questions from your venous disorders.